Good morning, this is Dr. Karthik Raj. So this is going to be an academic video on hip and groin examination, and he's Mr. Kumar, my model patient for the examination, Mr. Kumar. So I would like to examine your hip and groin for academic purpose. You have no problems on that, right?
Okay.
Thank you so much. So please come. So to start with the hip and groin examination, as I mentioned in all videos of mine, history taking, especially a detailed history on the acute and chronic issues of the patient is really important, but we're not going to concentrate much on that today because we're going to focus on the examination point of view. So hip and groin is not really isolated, so any involvement of the back is also going to play a role, and as well also the lower limbs. So starting with a quick examination, I would always love to start with the patient in standing. Could you please, standing posture. And I would also request him to take his shirts off if you don't mind. Yeah, okay. So the important thing I start with is to see the back symmetry of the patient. I'm sorry, back symmetry of the patient over here. Yeah, so starting with the bilateral shoulder level, that's important, which gives a clue, quick clue on the back symmetry over here, and also the centering position of the head, and any evidence of limb discrepancy, that's really important. And I examine or any pelvic tilt or obliquity that remains unnoted here. And also I like to see the patient from the front, from the side, and to see the normal lordosis and the kyphotic spinal curve. That's really important. And also to look for any abnormal prominence of the buttock, which could indirectly, because of the sagittal imbalance of the pelvis or the pelvic obliquity, that's going to happen. And also quick examination from this back, seeing the longitudinal alignment of the spine, if it's maintained, the head centered on the body, and shoulder contours, the pelvic alignment, and any evidence of bilateral calf muscle wasting. That's really important in this case. Thank you. I would like to make the patient take a few steps of walking, so that gives a good idea on dynamic assessment of the gait, and also the pelvic symmetry if it's maintained in the walking posture. Different forms of gait, starting from your Trendelenburg gaits, and which could specify on the pathology, but we need to focus on that. And the other point I would like to stress on here before starting to go for a full-fledged examination is the Trendelenburg sign of the test that we do for especially the hip pathology, wherein the abductors of the hip are affected. For that, I always make the patient stand here. Can you please stand? Yeah, stand this way. And the examiner, that's myself today, standing from the back of the patient, to stand straight, and to make him stand on single leg alternatively. Mr. Kumar, could you stand on this leg one, please? Yeah. For ideally, I make the patient stand for 30 seconds and compare the both side posterior superior iliac spine. If there's something to do with the abductors here, or not only the abductors, the neck or the hip joint per se, the abductor mechanism is going to weak, so that's not going to pull back the other side hip to maintain the alignment. So there's going to be a drop in the opposite pelvis if this side of the abductor involvement is there. Thank you. So I do it the other side to see the both sides of the abductor mechanism. That's really important to go ahead with. Would you mind? So again, I would have a quick examination of the patient sitting in this manner, looking at the knees and the lower leg anatomy. Gross examiner, look at the foot and ankle, the tibial alignment, the extensor mechanism, and the patellar alignment over here, and quickly running through the patient. Would you mind sitting this way? And also through the back, if there's any points of tenderness or any asymmetry, even any deformities of the back that could be easily noted, to see the levels of the scapular bony prominences, spine of scapula, the tips, to see for any scapular ringing or other involvements. And then I am very comfortable making the patient lie down to, can you please lie down? Yeah. So after like, you can come down. Thank you. So after this comfortable position, I would start the per se hip and groin examination. I would like starting it from anterior, lateral, and then posterior. As inspectatory findings of the gross lip, I would like to ideally, the patient needs to be stripped adequately, showing the bony prominences of the hip and even the low part, just covering the genitalia and abdomen should be free. But for the sake of model patient examination and for his personal comfort, I'm not doing it this way. But really adequate exposure is really important in this case actually. So starting with the inspection, I would like to look for the bony prominences of the anterior superior iliac spine and compare on either side how is it, and to look for any swelling or fullness on the anterior aspect of the hip region, any muscle wasting on the thighs or on the leg, and to look for the normal 15-degree outward looking patellas, the ceiling, not turned this side or that side, which is going to show any rotational deformities of the hip on either side, and also to compare the attitude of the hip, knee and ankle at the time to show any fixed deformities the hip is going to have. I would also like looking from the side to see if the trochanters, after stripping the patient, which I have not done here for the comfort of him, compare the trochanteric region if it's going to be possible visually, if only if the patient is going to be thin, and it's not really going to be possible in case of obese and bulky patients. And any abnormal swelling on one side could be evidence of trochanteric bursitis or any swelling on this side. And when I'm having a look from the side, I would also like to look for any exaggerated lumbar lordosis. Thank you. Look at the evidence of any exaggerated lumbar lordosis here after adequate exposure. And to do that, I need to make him lie on a very flat bed, ideally without any soft bed here. But for the model purpose, I'm not doing it for the comfort of the patient. And I would again turn this side. From back, I would like to look at the bony prominences, posterior superior iliac spine, and also the buttock on either side, any swelling on this side on the posterior aspect. That's really important. You can lie on the front. Now going to the palpatory points, I would start with again confirming my inspectatory findings, the anterior superior iliac spine, to look for that on either side, and also any joint bony tenderness over there. That's going to be the attachment of the sartorius, and the next bony prominence just below that is going to be the anterior inferior iliac spine, which is going to be the attachment point of the which is going to be the attachment point. The next point that's really important is that I go to palpate anteriorly the anterior hip joint, which is usually 2 centimeters or an inch below and lateral to the mid-inguinal point. Let me not confuse, it's not the midpoint of inguinal ligament, it's the mid-inguinal point, which is the point between the tip of the anterior superior iliac spine and the pubic symphysis. The line between these 2 points is going to be the exact point in between. This is going to be the midpoint of the mid-inguinal point. I'm sorry, not the midpoint of inguinal ligament. It's going to be the mid-inguinal point, and an inch below and lateral to that. On either side, if it's going to find the anterior joint plant tenderness here. And at the same time, let me palpate for any fullness, or do I feel any inguinal loads? That's really important. And if it's enlarged, it's going to be the vertical or the horizontal component of inguinal region. It's going to be, And the third thing that I would, the femoral triangle quickly, I would like to examine quickly here is to feel for the femoral pulsation on either side, and to compare it. It's going to be the same volume and not going to be any different this way than that way. And going on to the medial aspect, I would also like to examine the point here, that is the adductor tuberosity. I would like to see the point that's going to be the insertion point of all the adductors, like how anterior inferior iliac spine, you have the ilius, other muscles that's getting really attached to that. And the other important point anteriorly is also to have a quick look at the genitalia if it's any kind of a cause of inflammation for the inguinal nodes out here. From lateral, I'm going to see for any trochanteric symmetry on either side is going to be the leaves, the same level, or one is going to be upriding, the other one downriding. Is there going to be any trochanteric thirst tenderness in case of bursitis, or any snapping of the hip and other things? That's really very important. And please, still completely. Thank you. And here I again look for the posterior joint line tenderness and feel for any bony prominences here, and to palpate the sacroiliac joint from the posterior aspect. And also you can have a quick look on the spine examination if you had missed in the first. After I finished that, the pre-palpatory points, one point that I forgot before starting the palpation is to feel for any local warmth out here, because that's going to be really important before starting to go ahead with it. It's going to warm your fingers after you examine everything and go and feel for that. So that's a mistake which I did, and this time I should, that's really important by doing that first. And the other points is going to be the range of movements here. Quickly going through range of movements, this is important. Range of movements here. First I make the patient do it actively. Can you flex it? Yeah. He's going to flex it as much as possible. He's going to rotate at that side, please. Yeah, that's good. And rotation movements, abduction I'm not doing here because of the inconvenience of space. Abduction this way, that way. Abduction, adduction, and also I check for active extension by putting the patient on lateral position and do that. Second, I do it passively, looking for the flexion full range. This time I'm going to stress on the terminal range if there's going to have any pain over here. And while I'm doing this, checking for the flexion of the hip, I also do something special test called the Thomas test to look for any fixed flexion deformity of the hip. Ideally, this is done in a flat surface, not kind of a bed, but for the comfort of the model patient. I'm not doing it here. So I put my hand here initially to see if the lumbar lordosis is obliterated, if it's going to be an exaggerated lumbar lordosis, which will allow my hand to easily pass through. So I go ahead flexing the unaffected hip till there's obliteration of the exaggerated lumbar lordosis, and at that point I stop here and see the side, how much of hip it's flexed, and I can usually measure with a goniometer. For example, if it's going to be this much, it's going to be fixed flexion deformity of 30 degrees, and I give a tap over the thigh if it's correctable or not. If not, it's going to be the fixed flexion deformity of hip 30 degrees. Again, there's going to be a confusion if even it's going to be because of the FMD of the knee, which can be confirmed by taking the patient to the edge of the table and then extending the knee. So that's going to be a point on that. The other passive range being the abduction range. I keep my hand on the pelvis to see the pelvis doesn't move till the limit. And the adduction, while checking on the adduction, I put the other side leg down so that that's not going to hinder here. Seeing the adduction. Usually the range of movement is abduction is more than the adduction. This side going to be 40 to 50 degrees of abduction and 30 degrees, around 20 to 30 degrees of abduction here. And I'll also go for the internal and the external rotation, right? And this is going to be the internal rotation, is usually going 10 to 20 degrees, and external degree 30 to 40 degrees this way. It's not painful anyway here, there's no any rotational deformities here. And for the extension, please, I pick the patient to the lateral and try to extend the hip. It's going to be 10 to 15 degrees of extension out here. Yeah. So now the fourth important and the basic is going to be the measurements. The two measurements in the hip, that's going to be the apparent measurement, limb length measurement, and the true measurement. The apparent is going to be a fixed bony point, usually the surface sternum, from here to the tip of the medial malleolus on either side. The true measurement is going to be from the anterior superior iliac spine to the medial malleolar tip on either side. But before going on with the true measurement, I need to square the pelvis if it's unsquared, meaning I need to put both the anterior superior iliac spine on the same level if they're up this side or this side. Maybe that happens with the coronal plane deformity. So I need to square them and then go ahead with the true measurements here. The fourth thing is going to be the bulk of muscle measurements on the thigh, on the calf muscle, which usually I take it with reference to a bony point. For the thigh, usually we use with the anterior superior iliac spine. I take a measurement on the unaffected side with the maximum bulk, be it 30 centimeters. I use the same mark here to measure the bulk, and for the calf muscle is going to be the tibial tuberosity for the measurement of the muscle bulk. And now coming to the special tests of hip and groin region, there's a number of special tests. Even the Trendelenburg's test and sign that we did first, Thomas test is a special test which we did there. Apart from that, we have something to see on the other pathologies, like the active SLRT test, the Stinfield's test, which rules a lot of better. I make the patient to actively lift up the legs. This is going to rule a lot of, the hip pathologies on here, and also to look for any snapping of the hip on this side. You turn this side. Ask the patient to flex and extend and keep a hand on the greater candidates to see the IT band snapping on here and also here. If it's going to be here on distal aspect, it's called the Noble's test, that is looking for the IT band contraction, and a medial sign I can also see for the snapping of the iliopsoas, which is a good internal rotator of the hip. So I take it for internal rotator and look for the snapping and pain this side of the hip and groin examination. And I think there's a number of special tests for each component of here. I'm not really going to stress on all the tests because this video is going to cover only on the general aspect of hip and groin examination. The other point, but not the least, is going to be the distal neurovascular examination, the sensory and the motor examination. That's very important to rule out any involvement of neurological involvement in the back, or could be anything to do with the neurology, and especially in our part of the country where we still have polio, not active polio, but the residual palsy that happens because of the old polio. We need to have real look on the neurological examination here. It could be because of that, because of the contractures of that. So that's really important out here. That's concerned with the hip examination. So I think that's going to complete the hip examination. Thank you.